Good afternoon, everyone. My name is Pamela Browner-White, and I am the Chief Diversity Officer here at the American Board of Internal Medicine. This webinar today is celebrating the Hispanic Heritage Month, which honors cultures and contributions of both Hispanic and Latino Americans with heritage rooted in all Latin American countries. And by way of a heads up, as you saw earlier, we are recording, so if there's some reason why you shouldn't be on, you can excuse yourself now. We ask that you stay muted. There will be a time for Q&A, and we'll either have you put the question in chat, or we can take questions if you want to raise your hand. But for now, while we're going through the interview process, you can feel free to just mute your line. We'd appreciate it. So this afternoon, I have the unique honor of providing an introduction to our host, who is Dr. Lorna Lynn. She is our Vice President of Medical Education Research and the Executive Sponsor for the DEI Governance Committee. We work very closely together for the last 3 years on this DEI effort here at ABIM. And Dr. Dalia Magana, I hope I pronounced that somewhat closely, but I'm so glad to have you here today. She is the author of Building Confianza, Empowering Latinos Through Transcultural Healthcare Communication, and she is an associate professor at the University of California, Merced, in sociolinguistics. So welcome, Dalia. Welcome, Lorna. It's time for you all now to take over the program. We're looking so forward to hearing from you.
Thank you so much, Pamela. I'm delighted that you and Kelly asked me to host this because it gave me the opportunity to learn a little bit about Dalia's work, which is just phenomenal and important work for all of us to recognize. She's going to tell us a little bit more about it, but in preparing for this, I took a look at the start of her book, which I am now ordering because I want to read the whole thing. But I was so moved by the prologue that I asked her if she would read the first paragraph of that as a way of starting off, and then she's going to show us a few slides and give us some background before we start our conversation.
Thank you so much, Lorna. Thank you for this invitation. I'm so grateful to be here, to be talking to you all, and what an honor. This is a dream. Like, this is why I do the work that I do, to have this kind of platform to be able to reach the people that are taking care of Latino populations here in the US. So I'll read that first paragraph. So I began interpreting for my mother at age 6. My awareness of how language and cultural differences disadvantage immigrants in the US grew naturally from interpreting for her. My mother came to San Jose, California, from a rural town in Mexico 2 years before I was born. She moved to help her family back in Mexico. She came here to provide basic opportunities for herself and her future children. So I have 2 younger brothers, and she became a single mom very quickly. She supported us by working night shifts as a janitor, where she spoke Spanish with her boss and coworkers. And although she enrolled in English language classes, she never learned how to speak it. And she blamed it on herself all the time. I still have these memories that she would say that she wasn't capable. She was just not good at learning school subjects. But the truth was that she herself had basic literacy in Spanish. So when she would go into these English language classes, they assume that you know how to read and write, right? You have that basis of literacy, and she did not have that. So how could she learn a new language when she's also still learning the basics of literacy? So her not knowing English caused many cultural barriers, many language barriers, and the most dangerous ones have been in health. And I wanted to share a couple of those with you today as we start here, so that I can connect it to why I do the work that I do, why I work with the populations I do. So we can switch slide. So we often hear about people, the wealthy people in the Silicon Valley, the tech people behind the tech industries, but there's also a strong Latino presence. And for the first generation of Latinos that are there, many are immigrant, living in poverty, and that includes my family. So my mom got pulled from her town in Mexico because there was this need in the US to work in these industries, for example, the service industry and maintenance workers. So she became a janitor. And we lived in extreme poverty. We had limited access to healthy food. Cheap food, junk food was advertised to us daily. So here's a picture of my mom and me. On the left, she's eating an ice cream, and I am too. And then two other relatives. And then on the right side, me and my brother, my middle brother. So because of the environments that we lived in, we did not have safe spaces for exercises. Our neighborhood was considered dangerous. A lot of this then did affect our health, my mother's health. She gained weight very quickly. She had many health issues. She had a lot of daily stressors, including not knowing English, not knowing English meant that she was stuck in that job that paid her very little for the hard work that she was doing. And so, yeah, I've been interpreting for her most of my life. And one very dangerous incident was when she came away 12 years ago from an appointment with her oncologist, thinking she did not have cancer. We can switch the slide. She told me, she reported to me, and she said, I might get it in the future, but right now the doctor says I'm clear. I'm okay. And I said, Mom, how can the doctor know that you might get it in the future? When exactly? How did she deliver this? Can we please schedule another appointment? And I want to be there. So then this time I was there, and the provider was just very frustrated and said, actually, we told your mother that we are recommending a mastectomy, and she's been non-compliant. She has not returned our calls. She has not followed the next steps. This is a very treatable cancer. It was stage 1. And I asked my mom, why, the doctor told you this. Why did you say to me something else, that you might get it in the future? And she said she really didn't understand what she was being told, and she had an interpreter with her. For her, it was also her cultural beliefs. To her, cancer was a very strong word, and it meant death, because people in her hometown in Mexico died of cancer very often. She said she did not feel any lumps. So how could she allow someone to perform surgery when she doesn't feel it herself? She has some mistrust around providers because she was new to this country, because she didn't trust the system necessarily. She also believed that the cancer might spread if she had surgery. So months went by, and I talked to my mom, and I used her perspective because she's very religious. At one point she said, well, if God wants to take me home, let him, right? So she was already talking about like dying. I said, no, Mom, this is a very treatable cancer, and the doctor has a great plan for you. And, so then I worked with her belief system, and I told her, God wants you to help yourself, and God is working through your doctors. And with that, she did go ahead, and she went through with the mastectomy, just one breast, even though I talked to her, Mom, don't you just want to do both since you're already here? And it's, the doctor suggested that too, but it was optional, obviously. And she said no. So she has never been into preventative procedures. So that was 13 years ago. Sadly, about a year ago, she did start feeling a lump in her other breast, where the mastectomy, where she still has a breast. And she was supposed to get imaging, and she was supposed to get a biopsy, but one thing led to another, and she did not do that. She finally did get it about a month ago, and the doctor now needs a biopsy. But when she went in for her imaging, the technician performed them. And then with her limited English, she didn't have an interpreter. I was not there. And she asked the technician herself with her limited English, it's good? And the technician said, it's good. So then she called me and she said, I don't have cancer. The provider said, it's good. And I said, Mom, I think we need to wait until they send them to your doctor, and then the doctor will let us know what's going on and what she wants to do next. So sure enough, I talked to the doctor and she said, yeah, she needs a biopsy. And what I advocated was that my mom, she needs an interpreter even at these types of appointments where it's just imaging, because she was so excited. She thought she was done with this breast cancer illness, and she's not. We're still learning what's going on. So she has a biopsy scheduled in a couple of weeks. She has many conditions and she's only 60. So like an example of how the social determinants of health have affected her specifically, she has diabetes. She's got renal failure also. So she's been on dialysis for the last few years, getting dialysis 3 times a week, 3 hours a day. It impacts her life so much. She has high cholesterol, high blood pressure, hyperactive thyroid, and she's depressed. Most recently in May, she had a stroke. She lost most of her mobility. But now she's at home and she's in good hands. She has support. She does need help with everyday activities. And I don't live in San Jose. I live, fortunately, 2 hours away in Merced, which is an agricultural area of California. But from here, I'm able to arrange her appointments. She needs transportation for every appointment, medication refills, all that. So I'm the first contact for her. And fortunately, even though she lost her mobility cognitively, she did not suffer much memory loss, if any. But about a month ago, a dietitian called me and told me, your mom, I was speaking to her about her diet, but she's nonverbal. So I'm calling you because your mom doesn't speak, and it must be because of the stroke. And I asked her, well, did you speak Spanish to my mom? And she said, oh, no, I assumed she spoke English. So here we go, right? Labeling my mom as nonverbal because this dietitian did not speak her language. And that's an issue. That's been an issue in Latinx communities, being perceived as deficient because of not speaking English. It happens to children. It happens to adults. We can switch to the next slide, please. So, impacted by my family life, in my work, I try to connect with local communities. Here in Merced, it's a majority Latinx or Latine population. And there's a small town called Planada, about 10 minutes away. And that's where I've been doing community engaged research. And that's through a partnership with a nonprofit called Healthy House. And they are my grant co-PIs. So some other researchers, they might partner with community-based organizations, and they'll pay them a stipend for helping them recruit people. But for me, this is a true partnership. And Healthy House is a co-PI on the grant. They received half of the award. And it's wonderful because it's the type of research that's meaningful to me. So yes, we interviewed people about their cancer stories. So we were interviewing Latinas who are breast cancer survivors. We wanted to know their experiences navigating healthcare as non-English speakers. And we wanted to know how they understood cancer. But it didn't end there because Healthy House, because they're a nonprofit and they see themselves as advocate for underrepresented people, they reach out as in other events. So back in January, we had these severe floodings all over the place, but it really impacted this area, Planada. It's about 95% Latinos, high poverty area and low education area. Many Spanish speakers, many farm workers live there. And it has poor infrastructure. So when the flooding, so when we had those storms back in January, it impacted most of the people there. Many had to evacuate, and some were left without homes. So Healthy House, because I had partnered with them, all of the participants, and these are some of the participants here pictured. We had a Christmas party for them just to celebrate them, celebrate their stories, their survivorship. And they brought their Christmas joy. And that was right before the flood. So then the floods happened in January. Healthy House, they were quick to call every single one of our participants. What do you need? You know, how can we help you? So this project is not just about getting these interviews and we're done. Like, thank you for providing it for me. No, it's ongoing relationships with people, being advocates for people. We are learning from their stories. They're providing so much for us. And it is our job to continue to offer them services long beyond the project. So I believe it's a more humane way to do research. And this is the type of work I've been getting into. So, but yes, one of our goals was to understand how they understood cancer. Next slide, please. And what we learned was that they did not use the discourse around cancer that is very prevalent in the US and in some European countries as well. So it's very common to hear cancer being talked about as a war, where people are individual warriors going into battle, and it's a battle that can be won or lost. For example, I will fight to win this battle. This was not the language that these Latinos were using. And that language conflicts with their values of the group collectivism, of community orientation. Wars divide people. There's opponents and there's dominant subordinate relationships, and the more powerful one wins, right? In viewing cancer as war, the patient has to be strong, have a fighting spirit to not lose, right? And losing is like, we see it in obituaries often. This person lost their battle to cancer. You might not have control, you know, over the outcome, and it's stigmatizing to label people as losing the war to cancer. And we saw this language too through COVID-19, the war on COVID-19. This person lost their battle to COVID, battling for COVID, providers as heroes, and frontline workers, and the vaccine as ammunition. But this language doesn't resonate as much with the communities that I worked with, where they saw cancer as a journey. That was a metaphor that they were using, a journey, and it's filled with spirituality and it's filled with their family. So they would say things like, it's a hard road to go through, or God walked me through it and held my hands and guided my doctors. So instead of creating division or hostility, Latinas, their metaphor served to connect to people. They're displaying vulnerability and sharing the difficult moments of treatment. They're not saying they're strong or they're going to win. They're expressing love and gratitude to others who support them physically, emotionally, and attribute that support to their religious faith. And they're always grateful to God and to their doctors who God guided for their recovery. So they communicate the importance of loving themselves, loving their bodies. They're not fighting their bodies because to them, their bodies is God's creation. It's a gift. It's a blessing. And this is a comic that I worked with an illustrator because we want to report the findings back to the community. So many times, you know, we publish our work and then it's read mostly among more, you know, educated groups, but we want to make sure that this research also reaches the women that we worked with. So then this is one way to report the findings through illustrations and highlighting the key points here. And we have an English and then we have a Spanish version of this. So next slide. So one of the key takeaways of this work is that we need to better understand the views that women of color, Latinas in healthcare have to best serve them instead of imposing dominant discourse like cancer is war. So enhanced training of patient-centered care should include research on patients' views, how they view cancer, how can we create more welcoming spaces in healthcare. It goes back to the language choices that people make. And this is crucial, especially for people who face disadvantages in healthcare and disparities. Okay. So.
Wow, that's you've shared so much with us. And while when we met earlier in the week, we talked about a few questions that I plan to ask you, and I still will. There are a few thoughts that I have in response to this. So I love that shift in metaphor from a war to a journey. I think that's very beautiful and would be very helpful to many people. I also think your mother is a hero. I think that her story of coming here alone as a young woman in order to better her life, the lives of her future children, and the lives of those in her family who were still in Mexico is phenomenal. And it's a story that I think all of us listening, probably if we go back far enough in what we know of our own families, there is something akin to that. For me, it was a paternal grandfather coming as a 13-year-old from Sweden, not speaking English, working as a coal miner for many years. So I would just invite all of us to reflect and to think about how that is still ongoing with people who are coming to our country with all of our wealth and all of our opportunities and all that they could give us moving forward. I'm also really struck by the way there was a shifting of blame to your mother, that she was the non-compliant patient rather than the system acknowledging where they had failed her. And I'm thinking of how that decimates trust. How does a patient, how does her family continue to trust a system when suddenly she's being blamed for the bad stuff that happens? I wonder if you can comment on that.
Yeah, no, that's an excellent point. And that is where the mistrust comes from. So she doesn't necessarily view her providers as being on her side. She views them as opponents because of this blame that she feels that, yeah, she feels like she goes in and she will get reprimanded over, her choices. And this is, speaking to people here in the Central Valley too, they don't necessarily view themselves as, part of the team with providers working together for better healthcare. No, they use metaphors like coming into the consultation ready to defend themselves, or like having to bring someone with them. So to them, that's very important because they do feel vulnerable. So they feel like if they have a person there with them, it'll give them safety, it'll allow them to speak up. But the fact that they're coming in and they feel like they have to get ready for like an argument or a confrontation, and it's a stressful event. And I think it could be different. I think that all patients need to know that, providers are there on their side, working with them, working with their knowledge base. And so removing that deficit line of thinking. So even labeling people as limited English, right? What about if we highlight their strengths? They speak Spanish, right? And they're trying to learn English also. That's not always possible, but because it doesn't happen the other way around, right? We don't really talk about like providers being limited Spanish speak or limited other languages, right? We place that on the patients. So I think shifting some of the language around there can empower people more too.
Yeah, indeed. And one of the thoughts I had when we were preparing was remembering a professor that I had in college who used to say somebody who speaks 3 languages is trilingual, somebody who speaks 2 languages is bilingual, somebody who speaks 1 language is probably an American. And I think that is true for most physicians as well. And even those of us who may understand some Spanish may not know any medical Spanish. So we are very limited in our communication skills, and yet we reflect it back to it being the patient who's limited in English. With your work and what you've seen about language barriers in healthcare, what do you think we could think about in order to address them?
Yeah, that's a great point. And that's that office door sign, that's so funny. And yes, it's yeah, it's what yeah, very memorable. But yeah, so language barriers, they impact a lot of people. We saw it with COVID-19. Spanish speakers were experiencing confusion. They were vulnerable to misinformation. There was high death rates among Latino populations. A lot of it had to do with the language barriers that we have in our society. We were not ready from the beginning to offer information to people. There's also the digital divide. Not everyone has access to information that's available digitally. And we know from the research that a language discordance, when the providers don't speak patient's language, then there's just higher incidence of medical errors. Patients receive less health education. There's greater dissatisfaction among patients. Patients that are like not speaking English fluently, they're less likely to use primary and preventative services, and they're more likely to use emergency department services. So it's a bigger cost for all, really. So, and like an example of someone that I spoke to, one of the women that shared her breast cancer story, she speaks Spanish only, and she had just had a mastectomy, and she was visiting a nurse for her post-op, and that nurse started clipping away at the stitches, even though she knew that was way too early. And she knew that her provider had said like there was no need to remove them, but the nurse managed to clip 2 of them before the patient got very visibly upset, and then had to, like, you know, she was very stressed, started, you know, making you know, like she got loud, she got angry, and someone else came in and interpreted. And then she found out that, yeah, that was a medical error. And the patient was advised, she said, you can sue, you can actually sue because that shouldn't have happened to you. And there was a language barrier there that caused this. But, you know, this patient said, like, that's not within my belief system, causing harm to people. These people need their jobs. I don't want that nurse to lose her job, even though she made this error. Like, so that work ethic is so important for people. And she said, no, I don't want to sue, but I do want, you know, for this not to happen to other people. And so that was one example of a language barrier. There's many more. There's one of the people that helped us recruit Implanada. Her name is Fabiola Cervantes. She's an advocate, 2nd generation. Her mother is also 1st generation Mexican. And her son's mother-in-law died from breast cancer. And she truly feels that her life could have been spared. And there was a language barrier in the consultation with her. So this woman, her name was Maria Rojas. She was in her 50s. Got breast cancer. She underwent treatment. She went, I think, a lumpectomy, and then chemo. And then she had a consultation with her provider. And she had assumed that her cancer was in remission. And she celebrated. She had a party, and she said, you know, like, I'm going to celebrate this moment. I'm now cancer-free. But then she got really sick a few months later. The cancer came back. And then this time she went to her consultation with her daughter. And she had learned that at that initial consultation, the doctor had actually said, you need another round of chemo. So this woman died because by that point it was too late. And again, it was a language barrier. Again, people don't report this kind of thing. They don't want to cause harm. They don't want to spread evil. That's just not within the values that these people in these communities hold. So that was another incidence of these language barriers, how dangerous they can be. So what are some solutions? I think just continuing to promote language education, especially these medical Spanish courses, incentivizing when providers are bilingual, and then promoting the cultural values that people have so that they feel more welcomed in healthcare institutions. Training more with interpreters, so how to work with interpreters. Sometimes, interpreting situations are not ideal, but they do help, right?
Yeah.
But not everyone's trained to work with them, and not all interpreters are trained to take care of the interpersonal part of language, and that's meaningful. So they might overlook small talk or greeting, but to Latinos, this is really important because it aligns with the value of building trust, of simpatía, which is like friendliness, personalismo, valuing more personal relationships over institutional ones. So I think also allotting providers more time when there's an interpreted consultation, because you need it, because it's not, there's just another layer of discourse there that will have to happen. And it takes longer than if you're speaking directly to them. If someone has to interpret what you're saying back to the doctor and with the patient, that you need more time, and providers don't always get more time. They're so pressed for it.
We have a couple of questions or comments that relate to this. So I'd like to invite Florence to ask your question.
Yes, thank you. I really am enjoying your talk. It's so rich, and it's just reminding me that we all have an opportunity to have some awareness, because sometimes we could help make a difference for someone. My question is, has your mother ever had any Spanish speaking medical or health providers? And if yes, were those better interactions?
I can't name one provider that she's had, and she's had many providers,
Right.
but no, I don't think so. But the book that that Lorna mentioned is on a Spanish speaking provider. It's a case study, and it talks about the language choices that he makes with every patient, and how that does make a difference. For example, these are mental health consultations, so he's asking about their social history, and he normalizes the experiences of Latinos. So in some cases, he will ask, when you were a child, did you have to work? And that kind of thing. So, and then patients open up about that because it's normalizing the situation. And it just, they feel understood, they feel trusted. So there's many examples like this here, but specifically with my mom, no, it's mostly, and it's really sad, right? And we know the disparities with there's just not many Spanish speaking providers, not many Latino providers, and that's a big issue.
Right. Well, and I asked it that way because I know that the language barrier is one issue, but perceived class differences can be another issue. I mean, my mother was African American. English was her primary language. She was college educated, but she wasn't always treated that way by service providers. They made assumptions about her. And so even without a language barrier, you're sometimes spoken to in a way that creates barriers to care, because the relationship doesn't develop in the way that it could.
That's a great point. And thinking of people at their different intersections. And for the group of Latinos that I work with, yes, they're first generation, and they're also working class, and they're Spanish speakers. And I do feel like these are among the most vulnerable groups in our society. But yes, the issue of class, that does come up. So there was a study with interpreters that looked at interpreted conversations, and these interpreters did not share a background with the patients that they serve. So most of them were from Latin America, came here middle class, and they would correct the Spanish that the patients spoke. So they were not, and they would side with doctors, right? Because that's who they felt they should side with, because they worked for, the hospital. But yeah, they belittled patients because of their language. And that goes back to the issue of class and whose language is seen as prestigious and whose language is not. And what my book does, it advocates for the language of local communities, because that's what's going to make a difference, right? The colloquialisms, the way that they use language is going to help connect people, right? And that is the advice that providers get too, right? When you talk to people across classes, if you're talking to someone, who is working class, and you're going to ask about, you're not going to use big terms like, do you use intravenous, drugs? You can ask colloquially, do you shoot up, or try to reflect the language that's being used in the community, I think would go a long way.
Related to this, Brandon McKenna, I would love to invite you to share your comment.
Can you guys hear me?
Yes.
Sure. I only laughed because I wasn't prepared to speak. But yeah, my dad's a retired Spanish professor, fluent in Spanish. I actually lived in Madrid for a year in first grade. Apparently was fluent and then completely forgot it because I was young. But yeah, he spent a few years as a translator, volunteer translator at some of the local hospitals. I think he really enjoyed doing it, being retired. It gave him something to do and some meaning. I do also think that when he had to express like unfortunate news, especially to younger people, he found it quite depressing, and it kind of got him down a little bit. So I guess there's a challenge, maybe a challenge there, with that. And then he noticed some of the signage in the hospitals, the translations weren't always correct when going to Spanish. Tried to raise some awareness with that, but was not well received by administrators within the hospital, I think, when he did that. So those are some things that he ran into with his journey there.
Thanks for sharing that. That's so wonderful. Like it really does save lives if you're there helping people bridge those language barriers. And sometimes, yeah, it's language, but sometimes it's more than that. Sometimes it's with people that have basic literacy, helping them fill out paperwork, right? And people might go into, institutions with feelings of shame, like they're a burden, but then having people help them out, navigate, the system, helping with, making appointments and that kind of thing, it goes a long way.
So I'm gonna ask another question, then Pamela, I'm gonna turn to yours just to give you more warning than I gave Brendan. We invited you here, Dalia, as part of National Hispanic Heritage Month, and we know from the 2020 census that it's close to 19% of the U.S. population are reported as Hispanic. It's a very large group, and we know that it's also a very heterogeneous group. And I would be interested in your comments on that diversity and what that might mean in the healthcare setting. You've spoken to this about using the local language when possible, and you have spoken so beautifully about the trust building with the communities that you have been doing your work in. But I would love to take you up to the 30,000-foot view and see what your thoughts are.
Yeah, about the diversity, certainly, right? It's been a challenge, I think, historically to categorize Latino people into one, because we are just racially very diverse, Some Latinos are from different races. Some Latinos are Black, some Latinos are white, some Latinos are Indigenous, some Latinos are Asian. They're so racially very diverse. mix, ethnically, yeah, people come from different parts of Latin America and different norms, different colloquialisms, a very diverse group. It's dangerous to generalize all of them. Definitely. So I do welcome celebrating the diversity across groups, right? Mexicans, Salvadoreños, Hondureños, Central Americans, Puerto Ricans, Cubans, and yeah, just the growing population of Central Americans too. My experience is mostly with first generation immigrants and mostly Mexican background. And like I said, mostly Spanish monolinguals. I do feel like this is one of the groups that needs the most support. But for the past 10 years, I've also been teaching. Most of my students in my classes are Latino, Latina. Most have parents from Mexico or Central America. Some speak an indigenous language too from Mexico. So there are many differences. It's dangerous to generalize them, but at the same time, there are powerful similarities that unite them. Most do share Spanish as a spoken language or a heritage language. Some people might not speak it at all. Some Latinos might be very highly acculturated, and maybe for them, Spanish is more of a heritage language rather than a spoken language. And they're still, of course, Latino. So there's also cultural values that are especially important for the first generation group of Latinos. So like family orientation and respeto, respect for elders, collectivism, prioritizing group needs over individual needs. So it's very frowned upon to like think about yourself only or putting yourself in front of the group. But I think, so yeah, there's a culture that does hold a lot of them together, and there's also similar struggles, right? History of colonialism, immigration stories, and I think it is important to recognize the different groups as, the category of Latino, Latina, Latine. Latines gaining more popularity in Latin America because it's easier to pronounce in Spanish compared to Latinx, right? So Latinx, I do applaud and celebrate the inclusivity of it. And I love that we're breaking away from the gender binary that Spanish creates. And, we have feminine and we have masculine, and masculine is O and feminine is A. But then there's always the default to the masculine, right? And that goes back to patriarchy. So in my classes, say I mostly have Latinas actually, and I'll have like 2 or 3 males, but it's like 30 females. Even then I have to say los estudiantes. I have to address them as the masculine, even though they are the majority. And so that's what the language dictates, right? But breaking away from that, I welcome that. With Latinx, it's gaining popularity, especially because of how it was started and the social media influence. But Latine, that's also coming. That's coming, and that's easier to have gender concordance. It's easier to pronounce too. So I think just being open to how people want to be labeled. I think that's what's crucial. And yes, celebrating their diversity, but also recognizing what unites them. Like there is Latino COVID crisis that hit Latinos across groups, right? Mexicans, Central Americans, Puerto Ricans. And it's important to understand their shared struggles, their shared experiences, and help connect their struggles to a larger conversation. And even not just among Latinos, but other communities of color in the US too.
So much of what you were saying it's knowledge and skills that could be taught to physicians, whether they speak Spanish or not, whether they have any kind of Hispanic heritage themselves or not. And I hope we see more and more of this incorporated into undergraduate medical education, continuing medical education as we move forward. But I want to turn to Pamela now. You asked a very thoughtful question in the chat, and I'd love for you to share that.
Thank you, Lorna. I was just thinking about the impact to the entire community. So being a caregiver to someone who's sick is a great responsibility. And then you have on top of it, the issue, the cultural, the language issues and so forth. So I was just thinking of you as a young woman, a young kid, really translating some very serious life or death issues to your parent and how complicated that all must be. And I'm just thinking about the caregiving community and do you do work with that community to help them transverse the medical, maze that folks have to go through in order to get help for their loved one?
That's such a great point. And I think that caregivers do need more recognition for the labor that they do, especially when they're helping immigrant communities, first generation, because they need, so much help with everything. For like my mom, it was filling out paperwork. There was a police encounter that I had to interpret when I was a child. And it's very stressful. And the research does show that children put into these situations suffer mental health consequences. And I have these discussions with my students, who most of them are second generation, also Latinos. So giving them a space to recognize their labor. Many times it's not recognized, it's invisible labor. It's the kind of thing that we just do because we're called upon it, because no one else can do it. So we just, support our families. And I am not formally doing this work, but I'm doing it informally and through these conversations with students. But I think we need to do more of it, understand the experiences of people offering care. And it's, even things like my mom's not able to access her medical records online, like some doctors will ask her to do, right? So it means like breaking it down for her in person, and that just requires more time with people. So I think that we do need to recognize, though, the work that that caregivers are giving, even providers who are Latino. And I think Lorna had mentioned this, the work, the very few providers that are Latino that we have in the US, the work that they're doing, they do so much invisible work because, they're like, when they understand the culture of the patients, they are helping break down those barriers, right? They are bridging health literacy, digital literacy, cultural differences, and even at the same time, they may be dealing with their own traumas, right? Poverty inflicts trauma on people. So if you're born from parents who are first generation, you may be dealing with that. You may be dealing with, you might have triggers from the patients that you work with that brings up that trauma. You might face microaggressions. I know I've been confused for a food server more than once, and all the time people are surprised that I'm a professor. They're, oh, wow, you're actually so, Latinos are not necessarily seen as the most intelligent group. And that's an issue.
Well, thank you for that. You're giving us all so much to think about. I'm going to combine a comment from Lindsay with a question that I had. Lindsay asked about any notable success stories in medical care in the Latina community you would like to share. And in thinking about that, and thinking about, how you had to think long and hard when asked by Florence if your mother had had any Spanish-speaking providers. We know there's an issue that we want to help address to broaden the pathway and make it smoother, the pathway into a career in medicine for Latina students beginning at the earliest of ages. So I'd be interested in your thoughts on that. We know there are so many reasons why this would be beneficial. It'd be beneficial to patients, to communities, and certainly to healthcare providers as we learn to understand this 19% of our population better through people who have the lived experience to share with us. So it's kind of a big question, kind of a general one, but I'd love your thoughts on that.
Yeah, thank you. Success stories. Yeah. So my book is on a case study of a provider who's bilingual, and that's really what it's about. It's been critiqued for not being like critical enough, but what I really wanted was a model of like how someone makes connections to people and the language choices that that person uses. So this provider, for example, when he interviews some patients who are bilingual, he and patients will code switch. We know in our society that that's not always celebrated, that bilinguals who switch from one language to another might sometimes be viewed as not being fluent in either language. The reality is that they are so fluent in both languages that they're able to switch in that way, and monolingual switch too, from let's say a more formal register to a more informal one. So this provider will adapt the interview to patients. So when patients would code switch, he would also code switch with them, even though for the provider, he's bilingual, but he was raised in Mexico City, middle class, and he came to the US to practice. But he adopted that that style of speaking because he wanted to make sure that people didn't feel excluded. So so there was this one patient who was saying in Spanish, cuando tenía 12 años, me hicieron brain surgery. When I was 12, I had brain surgery. So the doctor knows how, like, he continued the conversation in Spanish, but he kept the term brain surgery in English, because had he switched to Spanish, it would have been like correcting the person, right? Or teaching the person a new term. And that's not what his goal was. His goal was to make a connection, gain the trust of this person. So he said, oh, okay, dime cómo te fue con el brain surgery, you know? So using that term that the patient used to, again, normalize the situation. So yeah, many examples of how this happens. People are happier when they are provided with healthcare in their language. So it is really important. And even though there are very few physicians that are Latino, what we don't know necessarily is like whether they speak Spanish or not. And then the non-Latinos, right? Whether like what level of language they have. So I think it is a big, like we have a lot of work ahead, right? To build the Latino bilingual pipeline. And what does that mean? Like it means extra deliberate mentorship for Latino students. Especially because they might not have role models that look like them, especially because if they look at other doctors that don't look like them, they might feel like they don't belong. This creates insecurities, it creates imposter syndrome, it creates subconscious messages that they don't belong. So they need extra support. A way to do that is, yeah, just they may need extra mentorship, but also ways to highlight their strengths. So highlight their knowledge, their experience of Latinx culture, how it's a great asset to have that, to be bicultural, and then maybe create opportunities that will draw them. So courses on Spanish for healthcare providers, courses on developing cultural competence, courses that will highlight their strengths, I think would go a long way. And they'll feel like they have some advantage when yeah, they're the first in their family, say, to go to college. That's a big deal. And then supporting organizations that work hard to build the Latino pipeline. I'm working with the Medical Organization for Latino Advancement, MOLA, and they actually have a conference next week in Chicago. I'm part of the organizers for the medical Spanish portion of that conference. So yeah, it's a national association, and it's wonderful. And they're empowering the next generation of Latino providers.
Well, you have given us all so much to think about, and so much that inspires me, I know. And I think everyone here who has been listening to you, they're been a number of comments in the chat thanking you for telling your story. And our chief of staff had to leave early, but she said that this reminds her of work she did when she was with the city of Philadelphia and how important it is. It's beyond language, it's about culture. Um, you have made me think about things that I haven't thought about before, and I want to thank you for that. Thank you for your ongoing work, for the influence you will continue to have on generations of students, and for being with us today. And I hope that our paths will continue to cross. Don't be surprised if Pamela and Kelly and I reach back out to you again, because this has been just a terrific hour that has gone by very, very quickly. And I'll give you the last word if there's anything you'd like to say to the group.
Well, Lorna, no, thank you for this wonderful invitation, for your generosity and giving me this space, this time. And I'm just very grateful to be here with this group of people who are just so devoted to health equity, and supporting marginalized populations of our society that do so much to help us live the lives that we do, right? They do the type of labor that they do. Working as janitors, as farm workers for very little pay. And so I'm just very honored to be among this group that helps care for them. And so thank you for having me.
Well, thank you. I hope you have a good rest of your afternoon. Most of us have a little more work to do and then start on our weekends.